Hi, everybody. My name is Branka Šusic, and I work for Cotiviti, where we strengthen health outcomes by closing care gaps, identifying population risk, and engage members to take meaningful action through connected solution across quality and stars, risk adjustment, and engagement. I'm incredibly excited here to be with all of you today and to introduce a session here about maximizing risk adjustment performance with a PCP first strategy. Today we will hear from Fred Bloom, who is the president of Guthrie Medical Group, and Has Rifat, the CEO of Vatica Health. Welcome.
Thank you. So I'll go ahead and kick it off. As I said, my name's Hassan Rifat. I go by Haas, and this is Dr. Bloom. And so what I'd like to do is for Dr. Bloom just to introduce himself a little bit more and talk about, the health system that he's a part of, and then I'll tell you a little bit about Vatica, and then we'll kind of jump into our agenda. Go ahead, Dr. Bloom.
Yeah, very good. So I'm a family physician and the Chief Population Health Officer at the Guthrie Clinic. The Guthrie Clinic is in north central Pennsylvania and upstate New York. It's a rural integrated health system. We have 6 hospital campuses and 1,000 providers. About a quarter of those are primary care, a quarter are medical specialties, a quarter are surgical specialties, and a quarter are hospital-based. Now, our integrated health system does not have a health plan, but we do contract with all national and regional plans in our area. And it is primarily a rural service area. Our major referral center and level 1 trauma center is in a town of 5,000 people, Sayre, Pennsylvania.
Okay, I'll tell you a little bit about Vatica. Thank you. So we started the company a little over 14 years ago, and it was started by 2 brothers who put together a software application to do a compliant annual wellness visit. For those of you who remember that far back, that's when the Affordable Care Act came out. They enabled the annual wellness visit as really the first preventive service that was being reimbursed by Medicare. And when I met Abe and Steve, approximately a year and a half later, what really impressed me was that they were getting primary care providers to pay them for the primary care physician to leave the EMR and go do this work in the Vatica application to do a compliant annual wellness visit because they didn't have the templates in the EMR and they were failing, claims audits. What I immediately saw was primary care physicians' willingness to work in another system. I was a health plan. I'm a physician by training, but I'm really a health plan executive. I managed a lot of markets for Humana and Coventry. And when I saw the provider's willingness to do something outside their EMR, I basically said, we can make an enhanced annual wellness visit. We can do risk and quality work. And the 2 brothers liked that idea. I liked that idea. And off we went, starting in early 2014. And that's really how we've built the business. We support risk adjustment and quality of care. And you'll see a little bit more about that at the place of care, primary care, with the support of administrative teams as well as over 300 nurses that are helping providers do documentation and coding in our system. We've grown this business very nicely. When I started, we were doing about 200 or 300 visits a month. I think last year our peak month was about 40 or 45,000 visits a month. And we went from having just maybe 50 providers to having probably 6,000 or 7,000 primary care physicians spread across all these states that you see here. We've got lots of national and regional health plan sponsors. And we've been rated #1 in class for risk adjustment 3 years in a row, which I'm very proud of for our company, given that, we were the little guy and we were competing against a lot bigger players who are a lot better capitalized. But we had a vision for a PCP-centric model supported by a clinical team with strong data and tech operations behind it. And we stuck to that, and it has worked well in the market, since classes about customer surveys have said, you're the best. So we're very happy about that. I won't say anything more about Vatica. Okay, so I'm going to move on.
There are about 10 seats up here in the front, so people come forward and take some of these seats, please. I encourage you to do that. Of course, if you do that, it'll make it hard to leave early, so you have to wait.
Yeah. So I'm going to go ahead and just talk about market conditions a little bit, and after that, then Dr. Bloom will start to talk about his experience at Guthrie, and obviously, we'll both jump in, to each other's sections as we need to. So, right now, the health plans are experiencing a perfect storm. So you've got the migration from V24 to V28, which is, really dropped value in risk adjustment. You also have V08, which has got more robust value, but there's a lot more liabilities that are now being assumed by the health plan. So there's a lot of stress just in the risk adjustment model and premiums. The next thing you have is you have quality of care, right? You have all those thresholds that were depressed just by COVID relief that then were reinstated to full value that really, caught a lot of people off guard and created a lot of stress as it relates to quality of care. That makes it very difficult to get the kind of QBP in your bid or to, ultimately retain your membership. You also have the final RADV rule, which RADVs used to just be, fines defined on what kind of sample they looked at and your error rate within that sample. Now the government can fully extrapolate it, based on, the methods that they choose. And there's still just a blanket umbrella of scrutiny that the DOJ, OIG, and the various government agencies are putting on all things risk adjustment. It's a system that was put in place by the government, but the government's also very concerned about the abuse associated with it. I'm going to move through the slide pretty quickly. I'm assuming you guys all read the newspaper, and it's just, I never thought I'd be reading about risk adjustment in the newspaper. I always thought that, I was just sitting somewhere behind the scenes, doing good work, and, now it's just out there. 10 years ago, 15 years ago when I was running a health plan, I was relying on, retrospective chart retrieval and home assessments. And, I saw CMS applying a lot of pressure to those methods back then, and it made me nervous, and I was trying to figure out how to get more work done at the place of care, but really had a hard time. We would send forms out, we'd get a 1% response rate. We tried to have home assessment companies do more primary care in the home. They didn't want to touch the patient. If any of you have lived through that, it was really just very frustrating. Now I think things have really pivoted. I think, from the beginning, Vatica's always talked about doing things in the office should be the primary method, your primary strategy for risk adjustment and quality, and then you should use these other methods, to fill in gaps where you need to. When I was saying that 10 years ago, I think a lot of people looked at me and thought I was crazy because they were completely dependent on in-homes and retro. But I think most of the people, in this room would say that, they have either seriously moved towards an in-office program or are strongly considering it. Just by show of hands, we skipped something. How many of you represent payers? You work for a payer. Put your hand up. Okay. How many of you work for a provider? How many of you work for a vendor like us somewhere in the space? Okay, so that's what I feel for it.
Yeah.
Okay, good. So you can all relate to this. So it's important to understand that primary care physicians really are the hub at the center of the wheel. And there's a lot of things that have changed. There's a lot of patients accessing specialty care directly without the PCP's referral or without even knowledge of the PCP. But at the end of the day, the PCP ultimately is the best person to make sure that that patient gets the highest quality care they can at the lowest cost. And we've seen many times when risk is transferred to primary care physicians, they perform much better than they did when they were just getting paid fee for service. So we know, we have validation that primary care at the center, when properly supported, works well. Now it's just about how do you do that on a large scale. At the end of the day, being able to do risk adjustment and quality of care with access to the EMR when you support that primary care physician, and to let that primary care physician do their work directly. Them do the coding, not somebody else reading their words and selecting a code, but the provider selecting the code, the provider confirming the care plan, the provider closing a quality of care gap, or providing the documentation that can result in a CPT2 or G code. That's the best model. And it's really now about how to implement that on a large scale for the kind of membership distribution you have.
Yeah, that really aligns with Guthrie's approach. Our philosophy is that appropriate care and documentation should be a part of every single visit. And that we've moved away from a process where it's a once-a-year exercise or the annual wellness visit approach to a process where we integrate this with a workflow that our primary care providers are doing. But the key, the success for this, is in how tightly it's integrated into that workflow. If it requires too many more clicks or extra time or a delay as you go out to an external website and have to work through that, it's going to be frustrating, and providers are not going to want to do it. And we are really focused on our provider satisfaction at Guthrie. And so if the alerts are frustrating, we have the ability for our providers to tell us that right away, and we respond to that. And we either fix them or we turn them off. And so our provider response rate to BPAs at Guthrie, when you compare them to, we have Epic as our electronic medical record. If you compare them to the Epic universe, our provider response rate, Epic tells us, is amongst the highest of all their Epic clients.
Great. So I want to just share with you a little bit about our model so you have a perspective, the Vatican model, so you have a little bit of a perspective on how we do things. But I'm going to just make some general comments to try and give a little bit more perspective on the choices that are available. So in our solution, we're getting data from health plans, we're getting all kinds of file claims, MAO4s, MMRs. We're taking all that data and we're ingesting it so that we have normalized data from all payers. We then have nurses and field coordinators who are administrative with named access to EMRs, like at Dr. Bloom's practice at Guthrie. And so the first thing we're doing is we're looking for appointments. So we see that Mary Jones has an appointment coming up in 4 weeks. We can see that that's a member for one of our payers that we want to do a Vatica-supported encounter. And so our field coordinator initiates that case in the Vatica application. So that's where we've pulled the health plan data together. We've seen the scheduling data, either visually or that we're getting it through a feed, and we've set the case up. Sometime in that 4-week period prior to the encounter, our nurse, Vatica clinical coordinator with named EMR access, is going in and looking at all the data in the EMR. That visit prep takes usually about 45 minutes. With sicker patients, it's longer. With healthier patients, it's shorter, but on average, it's about 45 minutes. And what they're doing is they're gathering clinical information in that EMR around specific conditions that they believe clinically support that condition. They're also reconciling information from the health plan. So as an example, there's a medication list, and if we see that there's medications in the health plan data that's not in the EMR, then we flag that. And as you'll see in the next step, we have an EMR notification or a pre-encounter provider notification where we're saying, hey, here are the conditions that we believe exist based on the health plan data and what's in your EMR. Here's any quality of care gaps that are open. Here's any medications you need to reconcile. Providers do different things with that. Some people don't look at it. Other people want it put into an EMR alert. Other people want it printed and put in front of their chart. It's very important that you have optionality. It's really important. If I can't stress one thing enough, it's optionality, because the health systems are not the same and the providers within a health system are not the same. And you can't just say, okay, we're going to do it this way for a health system, and then you go down and talk to Dr. Bloom, and then you talk to Dr. Jones. They want something different. So having optionality all the way down the chain is very important. Okay? Then the patient visit occurs. We're not part of that patient visit. When the visit is done, we go back and we look at the encounter note, see if there's any additional clinical evidence that we want to bring in. And then Dr. Bloom would go into our system, In some cases, we're embedded within the EMR, like Epic and Athena. In other cases, we have single sign-on to just bring them right through, the doctor right through to our system, to that patient. And that's when the physician completes the coding exercise. They're actually presented all of the clinical content in one place, any encounter notes, consult notes, lab values, radiology. We've narrowed the set of ICD codes that are relevant based on the input of our nurses and our algorithms. Dr. Bloom can select the code he wants. He then brings up the meet screen, and we've pre-populated the meet screen with the appropriate values. Dr. Bloom can make edits, he saves it, and ultimately he signs, and that's the Vatica medical record, which is then ultimately either shot back through direct messaging to the EMR or manually put back in the EMR. In some cases, we also update the problem list or simply send the codes through integration back to the problem list to be processed however the clinician chooses. That's the process that completes the work with the provider. What we do at the last step is we have clinical coders who review 100% of the cases to make sure that the coding and documentation would be consistent with completing a RADV or a commercial audit or a Medicaid audit successfully, RADV or an IVA. And in the beginning, we would probably suppress, that's what we call it, something like 15% of the coding work. And we learned over time, over this decade, how to put more structure and controls in place, and at the same time do more education with providers, which we're very big on, and also ultimately improve our VCC training and our process so that we've now got that suppression rate under 5%. We've also got the time to do this work from, in the very beginning, I think it was 12 minutes down to about 4 minutes. Once a year per member. It's all it takes. We don't go back for another episode or encounter. We don't need to. We've tried to do repeat visits every year for the last 3 years on targeted populations, and we rarely have incremental pickup. It's a very complete process. It's very efficient. The providers enjoy it because they don't have to go looking around for information. They're not presented things that are just based on administrative data that's often noisy. So that's the process. I think the important reason I went through that is not to really tell you about the Vatica process, but to simply say all of these components are really important. And if you're selling a solution as a vendor that's tech only with data and it's going right through to the provider, you want to make sure you understand what kind of resources the provider has to support them when that information's coming through. Just passing things directly through to the provider, I don't believe is a winning strategy. I think it ultimately has to involve support that's either provided by the vendor, the health plan, or is already in place at the provider. And Dr. Bloom will tell you a little bit about his CDI team. You want to
Well, and
expand
so
on that?
that does address the concern that we had, is that we wanted a solution that was tightly integrated with the electronic medical record. As Haas was saying, we've been presented with a lot of solutions in the past where it was on paper, or you had to go to an outside site, or it was an extra step. And whenever we were balancing between, provider satisfaction and asking them or paying them to do something they didn't want to do, we always ended up on the provider satisfaction side of things. And so we've really focused on finding a way with an alert, an appropriate alert that's presented to the provider that makes it really easy to say they have this, they don't have this, or I don't know. And to respond to that alert and to move on and have that condition presented to them once a year. We have built a tool in our electronic medical record, started with Epic, and had gotten to that point, and we'll talk about how our journey there. But now I've started to contract with Vatica just this year because we believe that the Vatica tool has gotten to that stage where it has that tight level of integration. We have a tool, an alert, Epic. They used to call them best practice alerts. They're now our practice alerts, or OPAs. We have OPAs for our primary care physicians, but we've also started this year to have OPAs for our specialty physicians based on those diagnoses that are appropriate for their specialty that are presented to them. And so let me tell you about our journey. So our early efforts were around creating this alert, and the out-of-the-box OPA from Epic is not that good. As Haas was saying, if you just take all of the codes that you're presented with and throw those in front of your providers, there's a lot of junk there. And we realized early on that we needed a clinical documentation team to look at what was going to be presented to our providers ahead of time and to help them with that, to throw out the junk, to give them guidance, direction in the electronic medical record of where that documentation resided that would justify that diagnosis, to make it easier to move through that. And so we have worked to improve the out-of-the-box Epic OPA to make it more satisfying and less frustrating for our providers. We started working with Vatica this year, but Haas's team has been after me for a long time to work together, and every time it just seemed like it was one more step or one more thing that we were going to pay providers to do, but maybe would be a little bit frustrating. And so we had not contracted in the past, but have gotten to the point now where we've made that decision. And part of that was we acquired another hospital. We acquired in Binghamton an Ascension Lourdes facilities, and they had a different electronic medical record, and were using one of the other Vatica processes, and the providers were comfortable with that. And as we moved them onto Epic, our electronic medical record, and then showed them the new Epic Vatica alert, they were really excited about that because it was much easier than what they had been doing before. And so these new Guthrie physicians were asking for an alert, or the Vatica alert, that they, and a relationship. So we started to consider it again. At the same time, we joined ACO REACH, and we now have 20,000 fee-for-service Medicare patients where we are in a shared savings arrangement, and appropriate documentation is important for them. Well, our ambulatory CDI team wasn't able to take on an additional 20,000 people. And so we needed to make a decision. Do we grow our team, or do we partner with somebody who does similar work to what we're doing internally, and expand the capabilities, so that this allows us to delegate some of this work for some insurances to the Vatica team, and have our team work on Medicare fee-for-service, which is part of ACO REACH. And then, and so the legacy Lourdes physicians were asking for this. We had a business case for it from ACO REACH. So I went back to our providers, the legacy Guthrie providers, and said, well, I want you to look at that. And they said, really, Vatica again? You want us to look at this? And I said, no, really, it's better this time. And they looked at it, and it is better than what we'd presented in the past. And we're now implementing it and going forward. So what we've learned as we've done this is it's really about this workflow and how well you can integrate it into the workflow. We do a Press Ganey provider satisfaction survey every year. And one of the questions on that Press Ganey provider satisfaction survey is, are you satisfied with your electronic medical record? Our providers score consistently in the 90th percentile and above, sometimes as high as the 99th percentile of satisfaction with their electronic medical record. So we take this really seriously when our providers tell us they're not happy with something in the electronic medical record. We want to fix that. We want to make sure. Burnout is such an important factor in medicine, and we want to, the electronic medical record is a big part of that. We really want to try to focus on that satisfaction in all of our workflows. Again, I said we do this at all of our visits. It's not an annual exercise. Appropriate coding and documentation is a part of every single visit. not just an annual wellness visit. And we found that it doesn't have to be an all or none. You do it all yourself or you contract with somebody. You can have a hybrid approach to it where you do some and maybe you contract with some, or as we've done with Vatica this year. So this is our ambulatory CDI team. You'll see that it's actually nurse heavy. And we found that that was really important for us as we start to have these conversations and education, messaging with our providers. We needed people who could talk about the assessment and the clinical decisions that they were making and understood that, and nurses are better able to have those conversations with providers. And by having a nurse-heavy team, we have developed greater trust and cooperation with the team, and to allow us to be successful.
Yeah, I just make a quick point here. If you just look at the distribution of the resources, it's much more heavily weighted to clinical than to coding. That's an important point. You know, over the 10 years, we've watched CMS evolve and even publish that they have changed their perspective from coding verification to clinical validation. Those are two very different things, right? One is checking something against literally like a tech spec for a code. Another is saying, when you put a medical record under Dr. Bloom, would he believe that that condition is active and being managed or treated? That's what clinical validation is. So when you're working at the place of care, it's important that this is a clinical support and validation process, not a coding process. And I think a lot of the CQI and CDI teams at these health systems are heavily coding related, and that's ultimately not going to get the job done. I think there's a role for coders, but I don't think it's in this step of the process. And I think one of the things that aligned nicely with Guthrie, with Vatica, is that we had both taken a clinical orientation to the support for the physicians.
And so this is what our CDI team does. 60,000 charts reviewed. The top table there talks about the problem list work. And if there's a secret sauce to what our CDI team does, I think it's this problem list work. Our nurses are allowed to add diagnoses to the problem list. And once a diagnosis gets added to the problem list, it's more likely to be coded in the future, and it drives our alerts and reminders in the electronic medical record. So making sure the problem list is accurate and complete is a big part of what our CDI team does. But then they also do query our providers, and we have a pretty high success rate at acceptance to those queries, especially to the clinical queries. Our providers are much more open to discussions around, does a patient have this disease or not, and here's why we think they do, versus, well, you coded this code, it actually should be this code, and can you just change the code for me? And providers get frustrated with those kind of conversations. And so the clinical discussions our team is more successful with. These top HCC opportunities probably look familiar to all of you. This is based on last year, so this includes version 24 and version 28. And so, some of the things like vascular disease won't be a part of version 28 going forward.
Mm-hmm. And this is consistent with the data that we see in Medicare Advantage plans that we serve as well.
And so this gives you an idea of our team's improvement year over year. So this is a health plan report. One of our health plan gives us a report on the suspected diagnoses that they give us every year. So these are suspect diagnoses. And as we've grown our team and improved our OPA, we, year over year, have done better and better at addressing the suspected diseases for this one health plan, as an example.
Yes, and these results, once again, are consistent with our results. I think it's important here to take this away and to take my Vatica hat off and put it on the table. We're accomplishing things with our Vatica process, and Dr. Bloom has accomplished something similar with a CDI team that's heavily clinical, with how he has set up the Epic OPA. So there's more than one way to do this work and to be efficient and effective. It's really about the resources you have and your ability to actually implement this work into the clinical workflow in a way that's acceptable to the provider. Once again, I just want to say there's optionality that's important for you to hear, but there's also the opportunity to have different programs running at the same time to ultimately accomplish the best outcome in terms of quality and financial performance in the case of Dr. Bloom shifting his resources over to Medicare ACO and leveraging our program for our Medicare Advantage health plan sponsors.
And so one of the important components of the program is to give feedback to providers, to give reporting back to providers. And so we've created a report where we can show HCC recapture, BPA utilization, and panel rate seen. So the left side, the HCC recapture rate, this is a cumulative quarter over quarter throughout the year. And on the far right, the panel rate seen is a cumulative year over year or quarter over quarter throughout the year. The middle, though, is a quarterly snapshot so that we can see in any given quarter how people are reacting to our BPAs. Now, the HCC recapture rate, this is all patients, all payers, all diagnoses, the recapture rate. And we have some payers we have additional focus from our CDI team on, and so the percentages are higher, but this is all comers, all patients. In the payer rate, the panel seen rate, as you can see, climbs throughout the year. The BPA usage rate, when we first saw this, we had questions. Well, why does the BPA usage, why did it go down throughout the year? We found that a lot of the BPA responses, this is percentages, this is not the total BPA responses. The percentages people responded to early in the year, and as you do it once in the year, it's done. So the BPAs that are still firing at the end of the year are either those providers that maybe are a little more recalcitrant to the flow that we have. We have some of those at Guthrie too. Or maybe the specialists, some of our specialists aren't as engaged yet in this BPA flow. And so that some of these don't get, less of them fire in the fourth quarter, but less of them are acted on as well.
I'd just like to jump in with a few things on this one. So I just got this fresh. I don't have a slide for it, but I just want to show you, validate the same kind of experience in our programs. If you looked across all payers, you looked at 2024, 64% of the Vatica encounters had dates of service in the first half of the year. That's awesome, right? The ability to take those codes and do the early submissions for the September sweep, have a better informed bid around what kind of risk adjustment you can expect. For those of you who are more aggressive, you can take those codes, feed them into a predictive modeling engine to identify members that should have high-risk care management. You can also get an early view on changes to your denominator for quality of care. These kind of prospective in-office programs give you the opportunity to do things in the front half of the year, much more than what's typically occurring with other traditional methods of risk adjustment. Another stat is that 81% of the members that we serve are attributed to practices that had more than 70% completion rate of supported encounters, right? It's phenomenal, right? When we implement these programs, the providers are well engaged, and we are helping them to ensure that there's a high, what we call penetration or completion rate on those members. The last thing that's important is that if you look at 2025, we're just in kind of the middle of March, we already have visibility into over 60% of the upcoming appointments for these members for our health plan sponsors. So you have real confidence about the kind of projections that you make in a year to get something completed. And just compare that to what's happening with the traditional methods you use today. I think, before I had to convince people that in-office was the way to go. I think that there's enough data that everyone's seeing now that it has to be the primary strategy. The real question is how you build a program that ultimately is going to serve your health system, or if you're a health plan, how you're going to serve the different health systems and providers that are in your network. Okay, let's keep going.
So these are sort of a summary of what we found is that we have been able to delegate some of this CDI work to a partner. It can be a hybrid approach to things. This allows our in-house team to focus on populations we weren't able to focus on before, like Medicare fee-for-service. And the focus on every patient every time. Now, a provider may not have time at an acute visit to address the alert, but at a chronic visit or a routine office visit, annual visit, we expect that the alert would be acted on. And that feedback to the providers about their recapture rate, that data feedback, and we share it with our quality criteria. So we see recapture as a quality parameter, that patients are getting appropriate care for their diagnoses. And so we share that transparently. They can see how they're doing, how their partner's doing, how their other offices are doing. We have started to reimburse, and so with Vatica, there comes a reimbursement to using the Vatica alert. And this is the first time we've paid our providers to do this kind of work. There's interest in that. It's gotten their attention. And so we'll see. I guess we're hoping that now they're not going to say, pay me for those other alerts too. So we'll see how that works. But overall, we think that this strategy is going to be successful for us as we go forward.
Okay, I'll hit the key takeaways real quickly so we have a little time for questions. So the first point here is, the current state of risk adjustment solutions and quality of care for in-office, there's lots of choices, right? So, take the time to understand those choices. Consider all the users and stakeholders in your system, whether it's your health system or your network if you're a health plan. And, think about your culture in terms of, compliance and CDI and so forth, and, make sure you're doing something consistent with that. There's some people who want to be more aggressive with risk adjustment. There's other people who want to be more conservative with it. You have to take all those into consideration, and you have to make sure that you understand, the provider's perspective on that. I'll just, as a sidebar, tell you something very quickly. We put together our QI review process at the very end with clinical coders to make sure that we were being clear to our payer clients about the codes that we felt were submittable to the government and those that were not. What I didn't expect was when we went out to our providers, they were thanking us for doing the QI review because they had never been educated or trained about doing coding, and they had a peace of mind associated with someone reviewing their work on the back end. Just think about that. When I say think about all stakeholders, really ask them. You're going to find out things that you never really thought of yourself that are on their minds. In terms of provider selection of in-office solutions, I think the most important thing to say here is, number one, you got to think about provider experience and specifically making sure you're avoiding provider abrasion. And you have to think about the clinical outcomes and the financial performance that you're bringing into your organization or that you're offering that provider system if you're a health plan. I think the last thing that I want to say about the results is that when I was growing up running health plans, the adage was, well, if you want more compliance, you have to reduce yield. You have to make that trade-off. You have to be more aggressive about, not submitting conditions because you want higher compliance. In an in-office program, you can actually achieve high yield and high compliance. You don't have to make that trade. That's a very important point. I think a lot of people, that if you're in risk adjustment and you're responsible for it, you feel this pressure of, wow, I just had a big deflation with V28, but at the same time, I need to be more aggressive on yield. I'm also, being warned about everything that's happening in terms of compliance. How do I, solve those two problems at the same time? It's really putting the pen in the hand of the treating provider with the proper support and information so that they actually make the decisions, because those are completely defensible. And because they're taking care of the patient, they're going to produce the most amount of yield because they're the most clinically complete. The last thing I would say is, remember, everyone's in business, including Dr. Bloom. And when you're bringing out a program, it's important to understand what's already in place. And so Dr. Bloom was able to help us understand that he could shift the resources he had to his ACO business and leverage the programs that were being sponsored by our health plan. So remember, if you're going out as a health plan to a network provider, you want to think about their total business, not just your business with them. That's it. Thank you. I think we'll take questions now.